Cardiologist warns. 5 popular medications dangerous for the heart after 60. As a cardiothoracic surgeon with over 2 decades of experience, I have personally opened more than 2,000 chests and held countless human hearts in my hands. This intimate exposure has allowed me to witness firsthand the profound differences between a heart beating with robust vitality and one that is silently succumbing to decline. For many years, I observed that some of the most devastating damage I encountered on the operating table wasn't a direct consequence of poor diet, the detrimental effects of smoking, or even genetic predispositions. Instead, I began to recognize a more insidious culprit: medications. These were pills, often prescribed with the most benevolent intentions, that were, in quiet and often unrecognized ways, working against the very organ they were meant to support. I am Dr. Kevin Attawale, and I have spent 25 years operating on hearts that have reached the critical juncture where surgery is the last remaining option. Today, I want to illuminate 5 specific medications that are consumed daily by millions of individuals over the age of 60, medications whose potential long-term impacts are rarely, if ever, fully addressed within the confines of a typical 7-minute doctor's appointment. My intention is not to instill fear, but rather to equip you with the knowledge necessary to engage in more meaningful and informed conversations with your healthcare providers. The physiological landscape of the human body undergoes significant transformations after the age of 60, and these changes profoundly affect how our bodies process medications. Our kidneys, crucial for filtering waste products and excess drugs from the bloodstream, operate at a slower pace. Similarly, the liver, responsible for metabolizing a vast array of substances, experiences a reduction in its enzymatic efficiency. This means that drugs that might have been safely and effectively handled in younger years can now accumulate in the system or exert their effects for longer durations, potentially leading to unforeseen consequences. It is a statistical reality that the average American over 65 is concurrently taking 4 to 5 prescription medications, with some individuals managing 8 or even more. Each of these drugs, when prescribed in isolation, has undergone rigorous individual testing and received regulatory approval. However, the critical question that frequently goes unaddressed in routine clinical practice is: what happens when 3, 4, or more of these potent agents are introduced into a body that is already working harder to maintain its equilibrium? This complex interplay, this synergistic effect of multiple pharmacological agents within an aging system, is a question that almost invariably falls outside the scope of a brief, standard medical consultation. To illustrate this point more concretely, allow me to introduce you to a patient I'll refer to as Clarence. Clarence, a vibrant 74-year-old retired electrician, was the embodiment of proactive health management. He was sharp, meticulously careful about his well-being, adhered to a daily routine of walking 2 miles each morning, maintained a vigilant watch over his dietary intake, and by all accounts, had every reason to believe his health was firmly under his control. Yet, Clarence found himself presenting to me after experiencing his second significant cardiac event within an 18-month period. He was not merely tired, he was profoundly exhausted, a bone-deep weariness that no amount of sleep could alleviate. He was awakened in the throes of muscle cramps at precisely 3 a.m., and his cognitive faculties had begun to noticeably slow to a degree that genuinely frightened him. For 2 long years, Clarence consulted with 3 different physicians, each offering the same disheartening prognosis. Clarence, you're 74. This is just a natural part of aging. It was only when I took the time to meticulously review his complete medication list, every single drug and its precise dosage, that the underlying issue became glaringly apparent within a mere 5 minutes of examination. It wasn't a single problem. It was a confluence of 3 distinct issues, all stemming from his medication regimen that had been silently undermining his health for 2 years. Clarence's story is central to why I am making this video, and we will return to him shortly to understand how his journey ultimately unfolded. Let us now turn our attention to the first of these 5 medications, statins. If you are over the age of 65 in America, there is approximately a 1 in 3 chance that you are currently taking a statin. Names like atorvastatin, rosuvastatin, and simvastatin may vary, but their fundamental mechanism of action remains the same. It is a well-established and scientifically validated fact that statins save lives, particularly in individuals with pre-existing heart disease. The evidence supporting their efficacy in this context is clear and compelling, and I, like many of my colleagues, have prescribed them thousands of times with confidence in their benefits. However, there exists a significant consequence, a crucial detail often buried deep within the prescribing information, perhaps on page 14 of a lengthy document, that fundamentally alters our understanding of their impact. Statins exert their cholesterol-lowering effects by inhibiting a metabolic pathway known as the mevalonate pathway. While this pathway is indeed responsible for the production of cholesterol, it is also indispensable for the synthesis of CoQ10 or coenzyme Q10. This seemingly subtle distinction, the blockage of CoQ10 production, is what can change everything. CoQ10 is not merely a passive bystander in the body. It is, in essence, the vital fuel that powers our heart cells. Imagine it as the engine oil for your cardiovascular system. Without an adequate supply of this essential compound, the heart's engine begins to run inefficiently, exhibiting signs of strain and eventually succumbing to wear and tear. A comprehensive meta-analysis conducted in 2005, a study that has since been replicated numerous times, unequivocally demonstrated that statin therapy can lead to a depletion of CoQ10 blood levels by a staggering 30% to 50%. This represents a profound reduction in the very substance that the heart, the organ with the highest metabolic demand in the entire body, critically needs to function. The clinical manifestations of this deficiency can include persistent fatigue that is unresponsive to rest, generalized muscle weakness, a disconcerting mental fog, and, in a significant subset of patients, a measurable reduction in cardiac function. Clarence himself had been on a high-dose statin for 2 years, meaning his heart had been operating at a suboptimal capacity, running below its full potential for that entire duration. What should rightly anger you is that CoQ10 testing is not a standard practice. It is not included in clinical guidelines, and in many cases, insurance providers will not even cover the cost of such testing. CoQ10 is readily available over the counter, meaning there is no patent, no substantial profit margin, and consequently, no inherent financial incentive for anyone to integrate its testing or supplementation into the standard treatment protocol. I am not suggesting a deliberate conspiracy, but rather highlighting a systemic issue where there is a distinct lack of incentive to ask an inconvenient yet vital question. The solution to this depletion is remarkably straightforward. Daily supplementation with 100 to 200 milligrams of CoQ10. The Q-Symbio trial, for instance, provided clear evidence of measurable improvements in heart failure patients who incorporated CoQ10 supplementation into their regimen. Therefore, the critical question you should pose at your next medical appointment is not whether you should stop your statin, but rather, should I be supplementing with CoQ10 alongside my statin? Please write this down before your next visit. Moving on to the second medication, this is one that often surprises people because it doesn't immediately present itself as a cardiac medication, and that is precisely what makes it so insidiously dangerous. I am referring to non-steroidal anti-inflammatory drugs, or NSAIDs. This class includes commonly used over-the-counter medications such as ibuprofen, naproxen, and diclofenac. These drugs are inexpensive and found in virtually every medicine cabinet across America. Most individuals perceive ibuprofen and its counterparts as mere inflammation reducers. They reason that since inflammation is detrimental to the heart, these medications must, at worst, be neutral in their cardiac impact. This line of reasoning, however, is precisely backwards. NSAIDs function by blocking enzymes known as KOX enzymes specifically COX2. The crucial role of COX2 is the production of prostacyclin, a vital natural protector of our blood vessels. Prostacyclin plays a pivotal role in maintaining the flexibility of vessel walls and, critically, in preventing the formation of dangerous blood clots. When COX2 is blocked by NSAIDs, this protective mechanism is effectively removed. Simultaneously, and of great consequence, regular NSAID use has been shown to elevate blood pressure by an average of 3 to 5 millimeters of mercury. While this increase may sound modest in isolation, for individuals over 60 whose arterial walls have already lost some of their natural elasticity, this chronic elevation of blood pressure can significantly escalate the risk of stroke over time. The gravity of this risk led the Food and Drug Administration, FDA, to issue a black box warning on NSAIDs in 2015. A warning that explicitly highlights not only the risk of gastrointestinal bleeding, but also, and critically, the increased likelihood of heart attack and stroke. This warning is currently present on the labels of these medications. Clarence, to his detriment, had been taking ibuprofen every single day for 2 years. His physician was aware of his daily regimen, yet tragically, no one flagged the significant cardiac risks associated with this chronic use. For individuals suffering from chronic joint pain, a more targeted approach is to inquire about topical NSAIDs, such as gels. These formulations deliver the anti-inflammatory effect directly to the affected area with minimal systemic absorption, thus circumventing many of the cardiovascular risks associated with oral administration. For managing underlying chronic inflammation, compounds like curcumin, often combined with piperine for enhanced absorption, have demonstrated promising evidence. Furthermore, a daily intake of 2 to 3 grams of omega-3 fatty acids, specifically EPA and DHA, boasts a stronger track record in cardiac health than many people realize. The Reduce It trial, a significant study, reported a remarkable 25% reduction in major cardiovascular events with high-dose omega-3 supplementation, a statistic that is indeed worth knowing and considering. It is imperative to reiterate that you should never discontinue any prescribed anti-inflammatory medication without first consulting your doctor. The ultimate goal here is to foster a more informed dialogue, not to encourage self-prescription or unsupervised cessation of vital medications. Our third medication is one that, embarrassingly, took the medical community a remarkably long time to fully recognize as a potential cardiac concern, precisely because it bears no resemblance to a typical heart medication. People readily purchase it without a prescription, consume it with their morning coffee, and rarely give it a second thought. I am referring to proton pump inhibitors, or PPIs. Common examples include omeprazole, pantoprazole, and lansoprazole. It is estimated that approximately 15% of the entire adult population in America relies on these medications, with many taking them for years and some for decades. What is often overlooked or buried in the literature is the fundamental role of stomach acid. Your stomach acid is not simply an unwanted byproduct. It serves as a critical gatekeeper, a vital component in the process of absorbing vitamin B12. When stomach acid production is chronically suppressed by PPIs, the absorption of vitamin B12 is also significantly impaired. This is not a minor reduction, it is an almost complete blockade of B12 absorption. Now you might wonder why a heart surgeon would be particularly concerned about vitamin B12. The answer lies in its indispensable role in metabolizing homocysteine. Homocysteine is an amino acid, and when it accumulates in the bloodstream, it can directly damage the delicate walls of our arteries. Elevated levels of homocysteine are recognized as an independent risk factor for cardiovascular events, a risk that, in some studies, is comparable to that associated with high cholesterol. Yet, this critical marker is almost entirely ignored in standard medical workups. A study published in the journal Gut in 2013 found that long-term PPI users exhibited vitamin B12 levels that were, on average, 30% lower than those of non-users. This finding is particularly concerning when viewed in the context that individuals over 60 naturally experience a decline in their ability to absorb vitamin B12 due to a reduction in intrinsic factor production by the stomach. Therefore, a drug-induced deficit is superimposed upon an age-related decline, creating a potentially significant deficiency. The symptoms of vitamin B12 deficiency can be insidious and often mistaken for normal aging: profound fatigue, memory impairment, and a subtle tingling sensation in the hands and feet that creeps in so gradually that it is barely noticeable at first. In severe and prolonged cases, this deficiency can lead to irreversible neurological damage, all stemming from a medication taken for heartburn for a decade, simply because vitamin B12 levels were never checked annually. But the impact of PPIs does not end with B12. They also deplete magnesium, a mineral that is involved in over 300 enzymatic reactions within the human body. For the heart, magnesium is crucial for regulating the electrical signals that maintain a steady and consistent heartbeat. A deficiency in magnesium is directly linked to arrhythmias and, as Clarence experienced, muscle cramps that strike in the middle of the night. Clarence's vitamin B12 levels came back critically low, and his magnesium levels were at the very bottom of the normal range. While technically within the established parameters, they were low enough to warrant concern, yet this was not acted upon by his medical team. If you are on a long-term PPI regimen, it is imperative to request testing for your vitamin B12 and magnesium levels. Furthermore, you should inquire about a plan for eventually tapering off the PPI if appropriate for your condition. For vitamin B12 supplementation, methylcobalamin, taken sublingually under the tongue in doses of 1,000 micrograms, bypasses the absorption issue entirely, as it does not require stomach acid. For magnesium, a chelated form, such as magnesium glycinate or malate, in doses of 200 to 400 mg daily, is far better absorbed than magnesium oxide, which is commonly found in cheaper, over-the-counter preparations. It is crucial to note that abruptly stopping a PPI can lead to a significant rebound effect, where stomach acid production surges back even more vigorously than before, making you feel worse and potentially leading you back to the drug. Therefore, any tapering should be done gradually under medical supervision. We have statins depleting CoQ10, NSAIDs removing vascular protection, and PPIs blocking essential B12 and magnesium. All three of these were present in Clarence's regimen simultaneously for 2 years, and tragically, no one connected the dots. Each specialist focused on their individual domain, failing to consider the cumulative impact of the combination over an extended period. We have 2 more medications to discuss, and these are areas where many physicians, myself included, harbored significant blind spots for years. Pill 4 involves a medication designed to prevent dangerous blood clots, yet it quietly accelerates a process that I have witnessed firsthand on the operating table. And Pill 5, that one involves a recommendation I myself made for 15 years, a recommendation that current data suggests may have been fundamentally flawed. I will share with you precisely what I told my own patients when I finally grappled with the implications of the accumulating evidence, and it was not an easy conversation. Please stay with me. The final 2 medications, particularly the 5th one, are what have fundamentally reshaped the way I practice medicine. Let's begin with pill number 4, warfarin. This anticoagulant has been in use since the 1950s and remains one of the most frequently prescribed medications for patients over 65 who are at risk of dangerous blood clots. It is a standard treatment for conditions such as atrial fibrillation, deep vein thrombosis, and for individuals with mechanical heart valves. Warfarin is highly effective in preventing these dangerous clots and significantly reduces the risk of stroke in patients with atrial fibrillation. I am not disputing its life-saving capabilities in these contexts. However, what the brief 7-minute appointment almost never addresses is its interaction with vitamin K. Warfarin functions by blocking the action of vitamin K but it cannot differentiate between the two forms of this essential vitamin. There are two primary forms of vitamin K, K1 and K2. While K1 is primarily involved in blood clotting, K2 plays a critical, albeit often overlooked, role in cardiovascular health. K2 activates a protein whose sole function is to prevent calcium from depositing in our arterial walls, instead directing it towards our bones where it is needed for structural integrity. When K2 activity is inhibited by warfarin, calcium, lacking its directed pathway, begins to drift and settle within the walls of our arteries. This deposition leads to arterial calcification, making the vessels rigid and inelastic, akin to pipes slowly filling with mineral deposits. Thus, while warfarin is diligently preventing dangerous clots, it is simultaneously neutralizing the body's primary defense mechanism against arterial calcification. A 2019 study published in the Journal of the American Heart Association revealed that long-term warfarin users exhibited significantly accelerated coronary artery calcification compared to carefully matched patients on newer anticoagulants, even in those whose physicians were actively trying to protect their cardiovascular health. As a surgeon, I have personally witnessed the challenges posed by heavily calcified coronary arteries. This calcification renders surgical procedures more complex, prolongs recovery times, and negatively impacts long-term outcomes. Does this mean that patients taking warfarin should immediately cease their medication? Absolutely not. The risk of stroke associated with untreated atrial fibrillation is substantial, approximately a 5% annual risk, which is certainly not a risk to be dismissed lightly. However, this information does underscore the importance of asking two specific questions during your next medical appointment. Firstly, considering the availability of newer anticoagulant options today, such as apixaban and rivaroxaban, which do not possess the same interference profile with K2, is warfarin still the optimal choice for my individual needs? Secondly, has anyone measured my coronary artery calcium score? This straightforward low-radiation CT scan provides a precise and invaluable snapshot of the current state of calcification within your arteries. It is one of the most underutilized cardiac risk assessment tools available, and the results can significantly influence treatment decisions and the overall management strategy. Now, let us turn our attention to pill number 5, a topic that is particularly challenging for me to discuss, not due to the scientific complexity, but because for years I myself recommended it confidently to patients who placed their trust in me. And as the data has revealed, I was wrong. I am referring to calcium supplements. If you are a woman over 60, there is a high probability that at least one physician has advised you to take calcium supplements, typically around 1,200 milligrams per day, often with the instruction to take it with food. This recommendation has become so routine, so ingrained as common sense, that it barely registers as a medical directive. However, in 2010, the British Medical Journal published a meta-analysis that gave me pause, a study that made me reevaluate years of practice. This comprehensive analysis, which synthesized data from 15 randomized controlled trials involving nearly 12,000 patients, revealed a startling finding. Calcium supplementation without the concurrent inclusion of K2 and D3 was associated with a 30% increase in cardiovascular event risk. Imagine a room of 100 women diligently taking their calcium supplement every morning, following their doctor's advice, believing they are actively safeguarding their bone health. The data suggests that approximately 30 of those women might, in fact, be meaningfully increasing their cardiac risk while operating under the assumption that they are pursuing a healthy practice. This phenomenon is often referred to as the calcium paradox. When supplemental calcium, devoid of K2 and D3, enters the bloodstream, it does so as a sudden, concentrated surge. Your body, faced with this sudden influx, struggles to efficiently distribute it to its intended destinations. Consequently, a portion of this excess calcium can end up depositing in the arterial walls, contributing to the very same calcification process we discussed in relation to warfarin, but in this instance, driven directly by the supplement itself. You take a pill ostensibly to protect your bones, and in doing so, it inadvertently calcifies your arteries. You might ask why, given this compelling evidence, guidelines haven't been more decisively updated. Reversing a recommendation that has been given to tens of millions of patients over 2 decades presents significant institutional complexities. Concerns about liability, coupled with established industries built around the sale of calcium supplements, often make it more expedient to add a discreet footnote than to openly acknowledge a past error. During the first 15 years of my practice, I routinely, almost reflexively, recommended calcium to elderly female patients. For a 68-year-old woman exhibiting early signs of bone density loss, calcium and vitamin D, 1,200 mg taken with food, was a standard, unwavering prescription. I was diligently practicing precisely what I had been taught. However, upon encountering the data from that BMJ study and truly absorbing its implications, I reflected on every patient to whom I had given that advice, every woman faithfully taking that supplement each morning. I felt a profound sense of responsibility, not guilt, because I could not have known what I did not know at the time. My responsibility shifted to ensuring that subsequent patients received the complete and accurate information. This is the very reason why this conversation matters so profoundly and why I am investing my time in creating this video. If you are currently taking calcium supplements, please do not stop abruptly, especially if you have documented bone density loss. Instead, bring this critical question to your doctor. Should I be taking K2 and D3 alongside my calcium supplement? For the vast majority of patients, the evidence-based answer is a resounding yes. K2 in the form of MK7 in doses of 100 micrograms daily and D3 with a minimum of 2,000 IU are recommended. Some individuals may require considerably higher doses based on their blood levels. Wherever possible, dietary sources of calcium, such as dairy products, leafy green vegetables, and small fish consumed with their bones, should be prioritized. Supplements should serve to fill nutritional gaps, not as the primary source of calcium. I have dedicated a significant portion of this video to discussing what certain medications can inadvertently take away from our bodies. Now allow me to spend a few moments focusing on what genuine heart protection truly entails, particularly after the age of 60. The good news is that much of this is not complicated, and crucially, most of it does not require a prescription. Omega-3 fatty acids, consumed daily at a dose of 2 to 3 grams of EPA and DHA, offer a potent trifecta of benefits. They reduce triglycerides, lower systemic inflammation, and actively help maintain the flexibility of our blood vessel walls. Magnesium, particularly in a chelated form, at 400 mg daily, is essential because after 60, dietary intake of magnesium often declines, while the body's demand remains constant. Adequate magnesium supports a healthy heart rhythm, helps regulate blood pressure, and contributes to better sleep. For chronic cardiovascular inflammation, curcumin with piperine offers genuine, research-backed benefits, not as a replacement for NSAIDs where they are medically necessary, but as a natural approach to addressing the underlying silent inflammation that can drive cardiac risk over many years. The data supporting its efficacy is compelling. Nattokinase, derived from fermented soybeans, has shown promise in promoting healthy blood flow and reducing excess fibrin, a protein that contributes to clot formation. Taurine, an amino acid, plays a vital role in supporting cardiac muscle function. Aged garlic extract has demonstrated meaningful data in improving blood pressure and arterial flexibility, and both nattokinase and aged garlic extract have long and well-established safety records. It is important to emphasize that none of these are magic bullets, nor do they replace essential prescribed medications. However, they represent crucial components that our bodies need to function optimally and that often get crowded out by our modern lifestyles and pharmaceutical interventions. Before your next medical appointment, there is one actionable step I urge you to take. Write down every single medication you are taking, every supplement, and the precise dosage of each. Then, at the top of this list, write three powerful words. What am I losing? Every drug carries a trade-off, a subtle exchange, and you have an absolute right to be fully informed about yours. Statins, while lowering cholesterol, can deplete CoQ10. Proton pump inhibitors, by suppressing stomach acid, can block the absorption of essential B12 and magnesium. Warfarin, in its quest to prevent clots, can accelerate arterial calcification. Calcium supplements intended to protect bones can, under certain conditions, harden your arteries. It is crucial to understand that none of these inherent trade-offs automatically mean that a prescribed medication is wrong for you. Rather, they signify that a complete and honest conversation about the full spectrum of effects is absolutely necessary. You deserve that complete conversation. Let me now return to Clarence. After meticulously reviewing his entire medication and supplement regimen, I sat down with him for a full 40 minutes, not the standard 7, dedicating our time to dissecting every drug, every dose, and every potential interaction. Following this in-depth session, I initiated calls to his cardiologist and his primary care physician. Together, we collaboratively developed a comprehensive plan. We initiated CoQ10 supplementation at 200 mg daily. Clarence's critically low B12 levels were addressed immediately with sublingual methylcobalamin. Chelated magnesium was added to his regimen. His daily ibuprofen was replaced with a topical diclofenac gel, providing the same anti-inflammatory benefits with approximately 90% less systemic exposure. His primary care physician initiated a gradual taper of his PPI medication. K2 and D3 were added alongside his existing calcium supplement. There were no dramatic interventions, no novel surgeries, and no groundbreaking new medications. We simply focused on ceasing the depletion of vital nutrients his heart needed to function and strategically replaced what was lost. That was all it took. 6 months later, Clarence called me. He expressed, with immense relief, "Dr. Adewale, I feel like myself again." For the first time in 2 years, the pervasive exhaustion had vanished. The excruciating 3:00 a.m. muscle cramps had ceased within the first month. Subsequent cardiac follow-ups revealed measurable improvements in his heart function. His primary care physician contacted me, genuinely perplexed, as Clarence's recovery did not align with the expected trajectory. The only significant change was that the complete picture of his health, encompassing the interplay of his medications and nutritional status, was finally being addressed. What strikes me most profoundly after 25 years in this field is not the complexity of what went wrong, but the surprising simplicity of what ultimately helped. A few targeted supplements, a strategic medication swap, and a 40-minute conversation that 3 prior appointments had simply failed to accommodate. The medications discussed today are not inherently villains, nor are the doctors who prescribe them necessarily negligent. The issue lies within a system that rewards the act of prescribing, but lacks any robust mechanism for rewarding thorough follow-up. There is insufficient time allocated to understanding what a combination of medications might be quietly doing to a patient's health over the course of 2 years. While you may not be able to change the entire healthcare system today, you can walk into your next appointment armed with your complete list and those 3 crucial words at the top. What am I losing? Sometimes this fundamental shift in preparedness is enough to initiate the necessary dialogue. If this information has resonated with you, please share it with someone who is managing multiple medications, whether it be a parent, a spouse, or a friend who has been told their fatigue is simply a consequence of aging. It may not be. Everything I have discussed is grounded in published scientific research and my extensive clinical experience as a cardiothoracic surgeon. However, your individual situation is unique. It is paramount that you bring these questions to your physician before making any changes to your medication or supplement regimen. This is intended to be the beginning of a conversation, not a substitute for one. Please take good care of your heart. It has been tirelessly beating for you every second of your life without ever asking for a break. The least we can do is to pay it the attention it so clearly deserves.